This is our presentation of patients with cancer and immunologic compromise. And our objectives, again, are the same objectives from your objectives in reading. Take a moment to look those over before going to the next slide. So some of this is going to be review. I'm not going to spend a lot of time on the first part of the presentation because it is review, but it always is, helpful as you guys are getting ready for HESEs or NCLEX, just to, if you understand the normal, then you'll understand the pathophysiology a little bit better. So carcinogenesis is depicted in the little box in the bottom right, where we have a initiation, promotion, progression phase to carcinogenesis. And it is possible, if the cells are able to be repaired or controlled by our genes and chromosomes, but at some point, as our immune system is kind of degrading, it becomes more and more difficult to stop the initial efforts of cancer to begin flourishing. And in immunocompromised patients, as we saw with HIV patients, certain types of cancers seem to erupt when the immune system is decreased. So, and again, initiation, promotion, progression. Some risk factors for developing cancer. We have endogenous and exogenous. So endogenous, you see our age, our genetics. We have some markers for familial cancer, the BRCAs. And BRCAs are just not for breast and ovarian. They're also in men. They're for prostate cancers as well. And I think that relates to pancreatic cancer. So there are multiple cancers for BRCA. Hormones, although they're not causative, they can be supportive, and you can see the cancers identified there. There are certain immune factors, which we just saw in HIV. The role is unsure, but immunosuppressed individuals and aging individuals with less vigorous immune systems have more appearances of cancers. And then risk factors are also various growths and lesions and polyps. Here we have a keratosis or a leukoplakia on the tongue. So this is like a precancerous irritation. In the oral cavity, you'll see those due to different endogenous factors such as smoking or alcohol use. And then here's our exogenous or modifiable. So chemicals or medications, so you see those as well. Alcohol and tobacco we just mentioned. Radiation, and that would definitely be the sun for our skin cancers, but also for occupational exposure. Nutrition, this one goes back and forth, but I think we have enough information now to say that high-fat diets, high red meat diets, low-fiber diets can contribute to risk for various cancers. Sexual history and then viral infections, you see those. What we see on our little picture is actually a human papilloma virus, which is on the hand in this individual, but that's much more known for causing cervical cancer in women, so that would not be located on the hand. But virus infection of HIV and hepatitis are known to be precursors to other cancers. Cancer is kind of typified by changing in cellular growth. If you are ever given a pathology report and you see the terms like primitive or abnormal or fetal appearance, so primitive or fetal appearances tend to be a more undifferentiated type of cell, which is suspicious of a cancer type of cell. So we see there are different alterations based on either excess or more or bigger cells, and those are typically benign presentations. But when you start seeing dysplasias and anaplasia, that can sometimes be a concerning change that might be a precursor to a neoplasm. Some compare and contrast with benign and malignancies, or malignant cell growth. You see benigns tend to be very localized. They're kind of well differentiated. They're as opposed to poorly differentiated means the growth is kind of reaching out into the tissues. It's not like a nice cyst presentation, which would be more like to be benign. And you see these, the one concern we would have for a benign growth that could be very dangerous would be in the skull. So even if it's a benign, if there's something causing pressure in the skull, that could lead to a very bad outcome. The other thing is we have these kind of general differentiations like rapid growth, spread. It's not encapsulated. It's kind of like this little tendrils reaching into the tissue and infiltrating areas. The real differential is not like, oh, that looks like a cancer. So you've got to get it under a microscope, and you have to look at it that way. Otherwise, we can't say, oh, it's probably just fine. Don't let your doctor tell you that. Or your patient. It would be like, well, I think we probably, let's chat with the physician about maybe doing a little bit more testing or biopsying here. Metastasis is a term used meaning that the cancer is spread beyond its primary site. It is more than not a poor prognostic factor for survival. They're not sure about the mechanism, so I'm not going to go into that. But you will, if you work in oncology, you'll see that primary sites tend to have a real specific pattern for where they distribute or metastasize to. Breast tends to go to bone, liver, lung. So same thing with specific sites for colon cancers and liver, lung cancers, and ovarian cancers have their distribution patterns. When we're classifying malignancies, you can see that it's a microscopic exam again. There's grading and staging, and usually the higher the number, the worse the prognosis. So if we have grade 0 to 4 under the microscope, then 0 is a normal cell. 4 would be abnormal and aggressive. As far as staging, you see 0 to 4, so a stage 0 would be that it's like encapsulated within the tumor, it's not moving beyond that. A 4 would be it's moved to various sites. If their staging includes the terms T, N, or M, or letters T, M, N, and M, you can see the tumor is identified as increasing in size and kind of how from not evident to increasing in size, Nodes means it is appearing in the lymph node system, and that's kind of the number and spread throughout the lymph node. And then metastasis would be from no metastasis, it's just isolated within the tumor, to multiple and distant metastases. Here's a little depiction, if this helps a little bit. Again, you're not required to memorize this, but I think this is very helpful for practice. And again, you might have a quickie question on an exam about this. As far as cancer therapies, I'm just going to summarize some of the therapies, then we'll look at the complications. So surgical diagnosis, surgical interventions for cancer therapies, we have a variety of purposes for that. It can be for diagnosis. It can be for staging. It can be for as an adjuvant therapy. Anytime you see adjuvant, that's the in addition to. So it would mean that there's another therapy happening, whether it's chemotherapy, whether it's radiation therapy, but it's combined with another therapy. Sometimes cancer surgeries are done to control emergencies such as obstructions, and that way it's not really going to potentially to cure something, but it will potentially give an individual longer life if that's what they want. And then there are surgeries for palliation. It could be inserting feeding tubes or debulking for more for comfort. And those are certainly allowable and understandable. As far as cancer surgery, here's a little nice depiction from a previous Lewis text that I liked and I kept. So you can see it's diagnostic, it's prevention, it's palliation. So it's a little bit of what we just talked about in the previous slide. As far as the patient undergoing surgery for any type of cancer, there's typically a team approach. Your oncology clinical specialists or APNs are wonderful. The physicians usually will sit down and go over all of the options. There might be an attending, there might be a surgeon, there might be the oncologist that's going to do the follow-up and chemotherapy. As I said, there's specialists for oncology type of surgeries. And then again, there's other members of the team that are very helpful. So for the patient, they're really, they've got probably a major shock to have this diagnosis. This is where they meet their team and develop your therapeutic relationship with your patient. If possible, they will want the patient to, schedule the surgery as soon as possible, but this gives them a chance to make sure if they have hydration needs, if they need a blood transfusion, anything they can do to optimize their status and their outcome. Nutrition, again, if there's time enough to make sure they're in good nutritional status, you see some interventions there. The patient and family, they can talk about infection prevention post-surgery and pre-surgery too. They want the patient in good shape for surgery. And you can see some other type of nursing care, patient care that the team is focused on. Besides surgery, the patient might need radiation therapy as well, and you can see more than half of them do. The general principles is once the cancer is identified, there are specific, cancers that respond to radiation. Some don't, so they won't bother with radiation. But there's some general principles. There's usually a physicist involved with radiation therapy, and they help calculate the dose and decide on the dosing via the radiation, whatever process they use for radiation. So they decide on a maximum dose that was felt that it will alleviate the cancer. And then the dose is divided and it's delivered over several weeks. So there might be so many sessions per week over 7 weeks or whatever. And this, they don't decide on the maximum dose and just give it all at once. It's just too damaging to the normal tissues. And this allows the tissue to repair between the doses if it's spread out. It's a little bit better on the patient, and they have more success this way. The other thing is that the radiation is designed to go after those tissues that are growing faster, so the high growth rates are most susceptible and surprised. They'll select cancers that are dividing and growing rapidly for this type of therapy. It damages the DNA, it produces cellular death, and it also damages normal tissue. So depending on where the radiation was in the body, we can see effects years later. It might be that if it's in an area with a lot of blood vessels, they might be weakening of blood vessels. They may be causing aneurysms later or pulmonary damage later. So they're careful with this, and they do need to do follow-up with patients for years. The radiation can be done externally, like beam radiation, or it can be done internally, such as like seeding with radiation. Let's look at a little bit of this. External is beam therapy. It can be delivered as a single therapy or combined with other therapies. And again, there's a radiation oncologist and a physicist, so not everyone does this. This is a specialty area. They will identify the area that they're going to use to consistently go through for the beams. So they identify like what part of the body needs to receive this radiation, and then they will mark the body sometimes it'll be like a tattoo. It might be there forever or for a long time. The other thing is if it's an area like the head that they really want to make sure the head is kept in place, or neck or facial radiation, they will actually have a mold that they make, and then the mold is placed over the face, secured to the table, so the patient gets the radiation beamed to the same spot every time for most effectiveness. They have the molds also for like prostate cancer, and it's very interesting because people have to make like molds of their rear end. They sit in this this mold, and every time they come in, they have to find the mold of their rear end on the wall, and they set it up in the radiation area, and the patient kind of wiggles into the mold, so they know exactly where to give the radiation every time. Kind of interesting and weird, but that's how it's done. They can do some intense modulated radiation, which is a little more precise, and again, this is like head and then prostate, which is why they need the molds. And they can also do this radiation in concert with surgery. There's a couple possibilities, preoperative and postoperatively. And you can see preoperatively, they're trying to reduce the tumor size, get rid of any lymph node spread. But in that area, if the surgery follows that, there might be some delayed wound healing. If they do it postoperatively, they're doing it to follow surgery and kind of eliminate any remaining cancer cells. Here's internal radiation brachytherapy. You can see that they insert little pellets into the area. This is a depiction of brachytherapy for the breast, where they do little channels and then they insert the catheters where these channels are located. They leave the catheters in, and then like on a daily schedule, they introduce radiation pellets. They remove the radiation after a certain amount of time. They remove the catheters after a certain amount of time. And they can also do little pellets in the prostate as well. So this is just an internal method of radiation. Here's the radiation of the prostate. The depiction on the left is external beam. On the right, this would be the brachytherapy, or seeding the prostate. And you can see it's kind of unpleasant because they have to use a probe to identify where the rectum is. And that's so they don't accidentally seed anything too close to the rectum. It could form fistulas. The implant needle then places the seeds within the prostate while missing the bladder and the urethra. So it is kind of a tricky issue, and they put in multiple seeds around the area. This is not long-lasting radiation. Usually within 30 days, the effects are minimal, and the patient can resume regular contact with people. Oh, here's one of our immobilization devices. So you can see it's kind of a mesh. It's actually a hard mesh, and it's placed over the face. It's locked to the table, and they're not locked on there for very long. It's just a couple of minutes, and the beam radiation happens, and they're done. As far as the pellets, the big thing with like prostate pellets would be not to have like children or the spouse like sit on the lap at all until a certain amount of days has passed, to make sure the radiation is decreased. For safety, here's some of our issues. The rooms are specially designed. There's radiation precautions for disposing of any contaminated urine or feces, especially with internal radiation. And the big ways of reducing radiation exposure from implants placed in the body would be not to have the provider or the nurse spend an excess amount of time in the room. Make sure if they can step in the room and ask questions or get something done via that way, that's fine. The greater distance is greater safety. Shielding might be used. This is one population where no pregnant caregivers are allowed in the room. And for personnel working in this area, they typically have these little badges, and the badges register how much radiation is being received by the individual. So if you're taking care of a patient who's had implants, they're in the hospital, they typically aren't in very long, but if they are in the hospital, group everything together. If it's like a cervical or a prostate implant, then you step in the room, you try to work from the head of the bed or the foot of the bed as much as possible, not next to where the radiation pellet is implanted. Some side effects from radiation: there are skin damage that happens, and it also affects any cells that turn over quickly. So the skin is constantly turning over. The bone marrow is very active. The GI tract, the whole mucosal lining of the GI tract proliferates a lot. So those are the areas that are affected most by radiation. And there's our late toxicity, blood vessels, pulmonary, even cataracts if there's been radiation around the head. It can cause some cancergenesis. So you see skin cancers and leukemias can erupt at a much later date. Strangely enough, people getting radiation get extremely fatigued. They just have a hard time even getting out of bed. Nothing is like, there's no other problem happening other than the severe fatigue, which passes after a while. A lot of skin reactions you can see. This was a radiation occupational exposure. There's some initial like redness following, like the skin starts peeling and it's dry, and then it becomes very wet, moist desquamation, hair loss. And you can see by day 24 there's a lot of abnormal skin presentation, particularly on the pointer finger there. There's radiation burns. And again, it looks like, just sunburn. So they typically are given emollients by the radiation oncologist or by the team there that are soothing to the skin. So here's some things we can do for our patients after radiation. Make sure the skin is clean. They can't use their usual lotions and potions. That has to be specifically identified by the physician. Sometimes you're not really sure what's in our emollients that we pick up at Ulta. Fatigue. Patients are going to be told that don't expect to be working at top speed at first. That will fade, but around the house you might not be making dinner. Have someone else do that for you. Nutrition: high protein, small meals. Due to radiation, and I said bone marrow, we have to watch all the bone marrow products. If they're suppressed and they develop any minor infection, they would need to be treated. You can see the antiemetics there, and then the patient family education. Radiation doesn't burn, it doesn't hurt. It's typically they turn the machine on, they turn it off within a few seconds, we're done. And then specifics regarding where they had their radiation. If they had head and neck radiation, they might have the mucositis, they might lose hair. Hair loss for radiation is permanent, by the way. If it's in the abdomen, they watch for blood in the urine and stool. And if the patient needs emergency treatment and they're at home, they should be calling for 911. I'm not going to go through all the chemotherapies. There's many, many, many chemotherapies, but it's helpful to know some of the biotherapies because these are the more emerging current therapies. So it's using our naturally occurring biologics, so our own cells, to improve the responses to cancer. You can see some of those. Cytokines and monoclonal antibodies. There are different cellular therapies, but it's all about stimulating the immune system to produce the good effect of reducing or fighting the cancer. So cytokines. Our two major cytokines are interferons and interleukins. You do not have to know the names or what type of cancer it's works with. So the cytokines are what we have in our body. They tend to produce kind of that flu-like symptoms, aches, pains, fever, anything you would experience with a good flu. It also has some other side effects of depressing our white counts. They can be a little depressed from this. These are only delivered IV or sub-Q, and you can see the interferons are produced by the T lymphocytes, so we try to activate that. The interleukins are given to stimulate the macrophages and lymphocytes. And again, it is just stimulating the normal defense systems to come and deal with the cancer. And they're getting very, very interesting, very good results for very specific types of cancers. There are some cytokines that don't really deal with cancers, but actually help in the recovery when people are in therapy for cancer. There are growth factors that the colony stimulating factors are wonderful. You see GCFS. This is our neutrophil stimulator, and the concern was years ago when people would get chemotherapy, sometimes they not die of the chemotherapy, the cancer, but they would die because their white counts went so low, an infection showed up and kills them. So that was like horrifying to be treating someone and they died from the treatment. So what they do now is with certain patients, they can watch their neutrophil count, and as it starts to dive down and leave them unprotected, they can give the GCSF, and their neutrophil count will be stimulated and they'll rebound. So when they get close to the nadir, or the lowest allowable point, and nadir is spelled NADIR, they'll give the GCSF and stimulate the neutrophils, and they'll bounce back. Now, since it's acting on the bone marrow, I didn't realize this until I had someone tell me that stuff works great, but my bones were just killing me. So she just said she felt like she'd been beaten up and had bone bruises, but that really activates the bone marrow. Epigen, EPO, is another cytokine, and you'll see that for red blood cell production. There's another cytokine for platelets called IL-11. So these have been wonderful and so helpful for patients undergoing chemotherapy. Monoclonal antibodies are also being employed. They bind with target antibodies and kind of signal, or these are like helper cells. They are usually administered via IV infusion, and they have the same kind of cytokine infusion complex syndrome, fever, chills, rigors in initial treatments. And this side effect fades over time, but so if it's mild, you can always remind the patient this will fade. However, it's frequent that they will give something for fever, such as Tylenol. They'll give an antihistamine, such as Benadryl or diphenhydramine, and then they'll give corticosteroids to kind of combat the side effects. So they would pre-medicate the patient to reduce symptoms. So there's a couple. Herceptin has been very helpful for patients with very late stage breast cancer. These, the Herceptin actually extends life quite a bit. Maggie Daly was the mayor's wife and had stage 4 breast cancer, and actually started on Herceptin right as it was coming out, and she lived for another 6 years due to this monoclonal antibody. Nursing implications, here's our pre-medication. Because of this infusion complex, hydration, warmth, fatigue, they might need no aspirin products, definitely, and that's because of that whole Rise syndrome potential problem. And you can see some other implications and nursing responsibilities for this. Other cellular therapies, I'm not going to really get into too many of these, but just want to give you a little bit of hint at what's out there. Cellular therapies using activated immune cells and immunostimulants. Angiogenesis inhibitors were thought to be the big scientific breakthrough maybe 2 decades ago, and it didn't turn out to be as effective. It's a very narrow application, but if you see, it is inhibiting the formation of blood cells that tumors use to feed themselves. So a tumor sets up shop, spreads out all its little blood vessels, and can happily feed away there. Well, the angiogenesis inhibitors come in and reduce and remove some of the vessels. So it's helpful in some cancers, but it's not as widespread or helpful as they thought it would be. As far as chemotherapy, the theory behind chemotherapy is to use the drugs. And now, chemotherapy are not biologics. These are just toxic drugs used to kill cells. So cell growth and the growth cycles are interrupted. There's some that are cell cycle specific, phase specific, and some just kill throughout the entire cell cycle. So if you remember way back into biology, the cell cycle would be like anaphase, telophase, metaphase. There's different phases. I think it's S phase and G phase. But anyway, the different phases, there's some chemos that work only on the specific phases and others that work in different phases. And the theory behind chemotherapy is that there is a ratio of cells that will be killed each time the chemo is given. So if you have a 90% kill ratio, the first time the chemo is given, it should kill 90% of the cancer. But there's 10% left. The next time it's given, it kills 90% of the remaining. There's still 10% left. And they have to do enough cycles of the chemotherapy to get down to the last, apparently, few cells in order to kill or damage them effectively. It's most effective when the tumor is really rapidly growing because it will really go after the dividing cells. It's most helpful if combinations are used because the drugs work a little bit differently, and so the approaches augment each other. One of the concerns with chemotherapy is there can be tumor resistance, and there can be like a resistance develop after exposure. There are a variety of chemotherapeutic agents. You see those listed below, and I'm really not going to hold you to any of those, just that these are drugs meant to kill cells, and they also kill normal cells that are rapidly growing too. Kind of the same issue with radiation. Here's our side effects. Normal cells are injured, and we have some of the similar ones, neutropenia, anemia, thrombocytopenia, so I'm not going to tell you those. You should know those. The blood counts are used to monitor that nadir, or the lowest point of the cell disruption. So for the bone marrow, it's all about preventing infection, preventing infection, preventing infection. GI is very affected. Lots of stomatitis, lots of nausea, even like bleeding from the mucosa. Hair follicles grow rapidly, so losing one's hair, hair is very personal. What does it mean to you? If you had to lose all of your hair, how would you feel about it? So it can be very traumatic. I know people who have gone and gotten their wigs picked out before they even start their chemo, or they've like, hey, I'm bald and I'm gonna embrace it. I'm gonna get the big earrings and some scarves and I'll be fine. But really, people need to address this before their hair is falling out and they have to go and get a wig made or a wig picked out. Some people choose after the chemotherapy starts and a little hair is lost to just go ahead and get their head shaved. Others wait longer, and people who wait just say, you know, at some point it's too much. I wake up in the morning and like there are big clumps of hair on my pillowcase. So I step in the shower and my hair is just falling off at my feet in the shower. And the individuals that they've usually gone to for hair cutting at whatever beauty salon, they're very good. If you just tell them I'll be getting chemotherapy and I'll be losing my hair, they're like, tell me when you want to, just call me when you need to have me take care of your hair, and we'll make an appointment that next day and you'll come in or that day. So they're very sensitive to that. Other side effects, as with radiation, fatigue. There might be some organ-specific toxicities, and some people are hypersensitive, so they would have a reaction to the chemo as well. Some administration, very special handling with IV chemotherapy. Oral chemotherapy can be given. You have to be careful for touching any pills, but any IV, people have to be chemo certified. They're contact inhalation, special chemo gloves, routes you see there. The IV is most common, and the whole thing is to make sure to have no escape of the chemotherapy into the local tissues, which could cause necrosis and lots of damage to the area. You see a picture of a little implantable portacath there, and that's typically the preferred long-term access. I'll show you a picture of a port, and I'm going to show you a picture of estravization. I don't think of it as chemotherapy, it was the back of the hand. Usually if anything is really toxic, they really don't want that in just a free-flowing IV. They really want an implantable port. And then drug calculations are based on the size of the patient and surface area. So let's look at a port. And you can see this is easily accessed. People can shower, bathe, swim, do whatever with their port. When it's accessed, there's a very specific policy for cleaning and aseptic technique. We do not want to get a port infected. That's a sure setup for sepsis. Here comes estravization. It's not going to look pretty, so if you want to have your hand on the clicker or have your hand on the mouse to move the picture, just beware. And you can see this is a whole estravization of the back of the hand. You can see the tendon showing. This is horrible. And this person will definitely need skin grafts for that. Nursing interventions for chemo. You can see what the education goals are. The more your patient knows, the better. Sometimes people don't want to know too much, so really gauge how much they need to know. But I would say the big thing is to let them know about the side effects and how to manage things and what they might be going through, because as soon as they get home, they're going to feel lost. Make sure they have a good number to call for someone who can help them with some of their questions. Infection. Bleeding precautions, especially if they have thrombocytopenia. Tissue perfusion, so anemia. I'm not saying too much because this should be review. Nausea and vomiting, very common. Here's some of our antiemetics, keep them well hydrated. Zofran is our miracle drug for chemo. Chemo-induced nausea. It's been extremely helpful to patients. So you know all the little things about if people are nauseated, just like very light with the food, crackers, real quick carbohydrates cause less nausea. Nutrition, patients sometimes are losing weight, and the appearance of looking wasted physically or nutritionally is called cachexia. So if we can control the nausea, good oral care, especially if they have mucositis. High calorie, high protein, remember those snacks. Supplements, TPN if it's really bad. Some adjuvant therapies will cause weight gain. So you might want to warn your patients if they're on one of those therapies. As far as mucositis, I would say this is one of the most stressful and painful complications. It doesn't seem like much. It's like, well, whatever. So they've got some sores on their mouth. They're just terrible sores. They can't eat. Anything that's, off moderate temperature is painful. Have them check their oral cavity from time to time. They can do mouth rinses as long as they're not alcohol-based, but only just like mild, warm salt solutions, warm water, a soft toothbrush for their teeth. They should not be doing anything with the sores on their mouth. Careful flossing to keep their gums as healthy as possible. They might be doing swish and swallows with like the xylocaine to anesthetize some of the pain, antimicrobials. And then body image. Just make sure they know that the hair will come back. And here's a very pleasant title of Hair Color Battleship Gray, and that indeed can appear. Also, sometimes when hair regrows, I know Professor Bosman allows me to talk about this, but when her hair came back, it was tight, kinky, curly hair, and then it eventually grew out to a more normal texture. But it was the Battleship Gray, and she was very unhappy when she says, "Oh, I would get up in the morning and there'd be just clumps of hair on my pillow. It was horrible." Here's mucositis. You can see it's all over the tongue. It's probably on the inner lining of the mouth. They can do a little peroxide to kind of clean the area. Saline, again, the swish and swallows. Sometimes the physicians have, there's one thing called Miracle Mouthwash that has a little bit of everything in it. It's wonderful. This is hair loss from chemotherapy, so different, might be lighter for a while and then might grow back in. Again, radiation will be permanent hair loss, so make sure your patient's aware of that. It might be just like part of their scalp has no hair, and they'll have to learn how to, comb the hair to cover it. Other treatment modalities, I'm not going to hold you to any of these, but there's bone marrow transplants for some cancers. Gene therapies are still in infancy phase. There's a lot of ethics regarding gene therapy, and the Jesse Gelsinger case, which I'm sure you went over in one of your courses, was a gene therapy gone horribly wrong. And there's some alternative therapies that are meant to supplement, kind of helping the patient focus on healing, make sure the patient lets the providers know if there's anything they're taking as far as herbal supplements. And these can be very helpful and effective. Now, oncologic emergencies. Please watch the oncologic emergency web link I gave you. That's very helpful. I find this the physician to have very good information. Let's look at a few here, but definitely you are required to listen to that information. Obstructions. We have superior vena cava, so this would be a venous system obstruction. So remember where the superior vena cava is. It's above the heart. And you can see the usual causes. And when you have a lung cancer obstructing the venous syndrome, the venous system, and kind of pressing on that area, the patient could easily have the dyspnea and the swelling from the backup of the venous circulation, prominent collateral veins. You'll see that in the visualization above. You see all the distension of the upper body veins. If they're having severe dyspnea, they might have trouble laying flat, which would be concerning for radiation. But you can see where that radiation or chemo would be possible to shrink the tumor. If the cause of this is a thrombus in the venous system, they would certainly use anticoagulation. And you can see the concerns about airway and cardiac output. Treatment, reduce the obstructing lesion. So the sooner we can see it and find it and treat it, the better. Obstruction, spinal cord compression. So we have primary or metastatic, and the signs and symptoms really depend on the location. If it's high, it's going to be respiratory, otherwise it'll be paralysis or paresthesias. Acute would be surgical interventions. I mean, if someone's losing their sensation, that is concerning. Remember, sensation, you'll hear this in the web link presentation, that sensation is lost much quicker than motor activity. So good assessments are critical. I had a former student call in the middle of the night and tell a neurologist that she thinks there's something going on with her patient. Neurologist ran out there and assessed, and sure enough, they were having a spinal cord compression. Neurosurgeon showed up at the crack of dawn, and the patient had the compression relieved and had the paralysis avoided. So, good going to one of the former students. There's other obstructions. Tracheal obstructions would obviously be very concerning. This is the view you have on your right. You can see the impingement of onto the trachea. So airway obstruction, this is an emergency that needs surgical reduction. For bowel obstructions, it could be, if this is a primary bowel obstruction due to colon cancer or secondary due to metastasis, here's some signs and symptoms. If the patient is advanced and having bowel obstructions due to quite a bit of metastasis and abdomen filled with metastasis, there might have to be some discussion as far as how much the patient and family wants done if it's a pre-terminal type of obstruction. So this would be a surgical reduction, but at some point, if the patient is advanced in their cancer and they've stopped treatment, recovering from a major bowel obstruction surgery might not be possible for some patients, so they would have to decide if they want to just do other nutrition options for a while or what the patient's wishes are. Increased intracranial pressure, very concerning. You can see the mental status changes, nausea, vomiting, headaches, and the causes. So it could be if there's hemorrhage, if there's tumors, these would be surgical interventions. Some things could be done by radiation if possible. You can see secondary issues after tumor resections. So that would be concerning. Metabolic, as far as hypercalcemia, that's hyper. So it's because of bone disease releasing too much calcium or metastasis in the bone. And you can see the concerns. You've got muscle weakness. Remember with hypocalcemia, we had muscle tetany with Schwastik's sign. With pancreatitis, this is the reverse, muscle weakness, dysrhythmias. Treatment, since there's too much, might be volume expansion and using calcitonin or dialysis. Other emergencies would include DICs, and you can see this is a chronic bleeding or due to sepsis. It could be caused from low platelet count, so they would need infusions of platelets. Another metabolic problem could be SIADH, which is an increase in ADH secretion. You can see the causes there. And that causes fluid and electrolyte balances, so we'd have to treat the imbalances. We will talk more about SIADH when we get to neurotrauma, because that is a side effect of increased intracranial pressure. And then there's some results of the cancer chemotherapy. This would be chemotherapy, and a very severe one with leukemias is tumor lysis syndrome, as the leukemias or lymphomas are being destroyed. The components within these cells are then released into the vascular system and cause severe electrolyte imbalances. You see those there: hyperphosphatemia, kalemia, uricemia, and hypocalcemia. So if your patient is getting treatment for these type of cancers, we'd have to be very careful to monitor the electrolytes seen below, and this needs a quick intervention. You can see this can cause severe damage to other organs, so lots of hydration to reduce the excess electrolytes, diuretics to remove as much as possible. You can see dialysis is definitely an option for these patients as well. So this is an urgent situation. Cardiac toxicities can be cumulative from too much chemotherapy. So the medications that cause, the chemotherapies that cause this are typically identified up to maximum dose. So once that maximum dose is hit, they cannot get any more of that medication. And you see Cytoxan and doxorubicin are two major chemotherapies that cause this. So they start with an echocardiogram, and if there's cardiac damage, they can actually get less of their maximum dose is going to be less than if someone has a normal echocardiogram. And finally, pulmonary toxicities. It can be after months of treatment, have concluded either chemo or radiation, and can result in even ARDS. So if pulmonary hypertension is present, it's difficult at best. The solution to pulmonary hypertension severe would be a lung transplant. They would probably not do that in this population. So that's our immunocompromised based on cancer therapies. Again, it's required that you observe the other the web link on oncology emergencies, and again, there's a little study guide to follow along with and make notes. And otherwise, thank you for your attention, and we'll catch up with you on Thursday for any questions regarding this discussion. Thank you. Have a good one. Be safe.